Hello everyone. I am myself Dr. Rajesh Gubba. In this particular session, I'll be discussing very important pericardial disorders in the cardiology, that is acute pericarditis. So what are all the various pericardial disorders are? One is your pericarditis, acute or chronic pericarditis. The other one is pericardial effusion and then cardiac tamponade, and then we have effusive constrictive pericarditis. So these are all the various pericardial disorders of which I'll be discussing acute pericarditis in this particular session. So, if you take the most common etiology, it is like idiopathic. We don't know what exactly is the cause. But what has been presumed to be the most common cause for acute pericarditis is the viral infections. And that too, in the viral infections, we have the Coxsackie virus and as well as the ecoviruses that are responsible for your pericarditis. And because it's an itis, it's an inflammation. So, what will be the common clinical presentation in the individual? The clinical presentation will be in the form of the chest pain. And that too, it's a sharp pain, it's a pleuritic type of chest pain. And how will you diagnose this acute pericarditis? One is the ECG, where you have global ST segment elevation except ST segment depression in the AVR. And how do you treat these patients? Because it's an inflammation, you need to give anti-inflammatory drugs, that is non-steroidal anti-inflammatory drugs like aspirin. And if not, you can give colchicine. And in refractory cases, you can also give steroids. So this is in short about like what exactly is acute pericarditis. So these patients, they usually present with a sharp pointed pain, and this particular pain will be increasing on inspiration. So that will be the usual clinical presentation in patients with the acute pericarditis. Now let me take up the detailed discussion of the acute pericarditis now. So if you take the clinical classification of the pericarditis, we have acute pericarditis, subacute, and as well as the chronic pericarditis. So acute pericarditis, we use this particular terminology if the duration of the pericarditis, if it is less than 6 weeks, and if it is 6 weeks to 6 months, then it is considered to be subacute pericarditis. And if the duration of the pericarditis, if it is more than 6 months, then we consider it as the chronic pericarditis. All right. Now, at the same time, you should be aware of the etiology causing the pericarditis as well, or like what is the type of the inflammation. If you take acute pericarditis, the type of inflammation will be the fibrinous pericarditis. And apart from the fibrinous pericarditis, we have another form, that is effusive constrictive pericarditis or effusive pericarditis. So what do you mean by the word effusive pericarditis? Effusive pericarditis means along with the inflammation, there is also presence of pericardial effusion. That is what is called as the effusive pericarditis. Then this particular effusion, what type of effusion is this? It is either serous effusion, right? Or it could be serosanguinous type of the effusion. Now, if you take the subacute pericarditis, what are the subtypes in this? In this also we have effusive, constrictive pericarditis, right? Effusive constrictive pericarditis, and the other one is, so effusive constrictive pericarditis is more, means what? You have the pericardial effusion and as well as the constrictive pericarditis. But whereas the other type, it is purely constrictive pericarditis, where you don't have the effusion at all. Okay, so these two are your subacute, where the duration of the pericarditis is around 6 weeks to 6 months. And if the duration of the pericarditis is like more than 6 months, that could be constrictive pericarditis, right? And the other one is non-constrictive, which is nothing but adhesive pericarditis. Okay, so these are this is the clinical classification of your pericarditis: acute, subacute, and as well as chronic. Less than 6 weeks, 6 weeks to 6 months, and then beyond 6 months. Now let me take up the discussion of the etiological classification of the pericarditis. So in the etiological classification, we have infectious, non-infectious, and as well as the autoimmune conditions, out of which you take the infectious causes for pericarditis. So the infectious causes for pericarditis, let me tell you, the most common will be the viral etiologies for causing pericarditis. And among the viral etiologies, these includes the Coxsackie A and as well as B virus. That is the most common virus. Then followed by that, we have ecovirus. Then next we have the herpes virus, next mumps, adenovirus, then hepatitis virus, and then we have HIV. So these are all the viral infections that can contribute to the development of the acute pericarditis. Whereas you take the pyogenic causes. So pyogenic causes, they include mainly the bacteria. These pyogenic causes include number one, pneumococcus, right, which is nothing but your strep pneumonia, right? And then we have staphylococcus, next Neisseria, next Listeria, and another important bacteria is the chlamydia. So these are the pyogenic causes for the development of the acute pericarditis. Then tuberculous pericarditis. This tuberculous pericarditis will not only cause acute, this is also the one which is responsible for chronic constrictive pericarditis as well. If you see the most common cause for chronic constrictive pericarditis in India, the most common cause will be the tuberculosis. And the fungal infections are very common. And these fungal infections, they include the fungal infection which will also cause Addison's or adenocortical insufficiency. And what is that fungal infection? That is histoplasmosis. And apart from this, we have the fungal infection which is very common in diabetic patients, that is candida. So even candida can cause the pericarditis. Apart from that, we have blastomycosis. Then lastly, we have coccidiomycosis. So these are the fungal infections which are responsible for the development of the pericarditis. And lastly, we have some of the other etiologies, mainly the sexually transmitted infection, that is syphilis. Then we have protozoal infections, right? And lastly, parasitic infections. Okay, so among all these, which is most common? That is viral infections. And among the viral infections, it is Coxsackie A and as well as Coxsackie B virus. So these are the infectious causes for your development of pericarditis. Now, let me take up the discussion of the non-infectious causes. Okay. So what are the non-infectious causes? These non-infectious causes, there are certain etiologies which will cause the acute. So this will be idiopathic. We don't know what exactly are the etiologies that will be causing non-infectious cause causing pericarditis. Next is the renal failure. So in patients with renal failure, there will be accumulation of urea within the pericardium resulting in uremic pericarditis. So uremic pericarditis, this is one of the non-infectious cause for the development of pericarditis. Next is certain malignancies or neoplasias. So we have the primary tumors and we have the secondary tumors. So secondary tumors are nothing but the one which are metastasizing to the pericardium. So you take the primary tumors. The primary tumors, like we have benign tumors, then we have malignant tumors. Okay. Then you take the secondary tumors. Secondary tumors, they are nothing but the metastatic tumors. The tumors that will metastasize to the heart, okay, or pericardium. Now, this metastasis, it is coming from the lung. Metastasis, it is coming from the breast, and metastasis in case of lymphoma and as well as the leukemia, right? So these are the neoplasias that contributes to the development of the pericarditis. And lastly, we have some cardiac conditions which can cause pericarditis, and these cardiac conditions include mainly trauma or injury to your pericardium. Okay, so one is trauma, right? Or you have done certain procedure like pericardiocentesis. So even pericardiocentesis can also predispose to the development of pericarditis. Okay, and then the other cardiac causes include the aortic dissection, right, where there is tearing of the aorta, where the individual will have severe tearing type of pain that will be starting from the central part of the chest and will be radiating to the back to the interscapular area. Okay, And the next important is trauma to the chest wall. Right, so these are the cardiac causes for the development of pericarditis. Then we have some metabolic causes for causing pericarditis, and these metabolic causes include hypothyroidism, that is myxedema, right? And another important metabolic condition include hypercholesterolemia or dyslipidemia, right? Or dyslipidemia. So these are the metabolic causes for the development of pericarditis. Okay, so what all we have discussed now? We have discussed infectious causes, out of which the most common will be the viral infection. Then we have non-infectious, like the most common will be idiopathic. We don't know what exactly is the cause. The others will be renal failure, neoplasia, cardiac and metabolic conditions. Then we have some etiologies of autoimmune origin that can cause pericarditis. You take in patients with the rheumatic fever. See, in patients with rheumatic fever, like which is secondary to group A, beta hemolytic, streptococcal, throat and as well as the skin infection. These patients, they develop pancarditis. Right, they develop pancarditis. So there will be pericarditis, myocarditis and as well as the endocarditis as well. That is what you will see in patients with the rheumatic fever. Then we have some collagen vascular diseases that can contribute to the development of pericarditis, and these collagen vascular diseases, they include the SLE, that is systemic lupus erythematosus. So in patients with SLE also, like you have pancarditis, that is like pericarditis, myocarditis and endocarditis, but most common will be pericarditis. And how will you diagnose SLE? SLE, that is, you have elevation of anti-neutrophilic antibody and as well as elevation of anti-dsDNA and anti-Smith antibody. Then next is the rheumatoid arthritis. Even this will also cause pericarditis, and the autoimmune antibody is anti-CCP, that is anti-cyclic citrullinated polypeptide, or the RA factor will be positive. Then next is the ankylosing spondylitis, where you have HLA-B27 being positive. Then scleroderma. So scleroderma will also cause pericarditis, which is also an autoimmune disorder. The antibody that is being formed is the anti-topoisomerase antibody or anti-SCL70. These are the antibodies that are being formed against the pericardium, causing pericarditis. Then very important is drug induced, and among the drug induced, very important is an anti-arrhythmic drug, which is a class 1 anti-arrhythmic drug, that is procainamide. Okay, and apart from that, we have an arteriolar vasodilator that will be causing pericarditis, that is hydralazine. Hydralazine is an arteriolar vasodilator which is used as an antihypertensive. Then we have an anti-epileptic drug, and that particular anti-epileptic drug is, right, that is phenytoin, that can cause even pericarditis. Okay, this phenytoin is used in both generalized and as well as the focal epilepsy. And we have a first line anti-tubercular drug, that is the isoniazid. Isoniazid is actually associated with hepatic dysfunction, and it will also cause peripheral neuropathy. And apart from that, this isoniazid will also cause the pericarditis. Then the another important antihypertensive, or like which will cause the arteriolar vasodilatation, is the minoxidil. Actually, minoxidil, one, yes, it has an antihypertensive effect, but where is it commonly used? Minoxidil is the one which is used in the treatment of the alopecia. Okay, right? And the other group of drugs are the anticoagulants, right? So these are the drugs which will be causing pericarditis. Then we have Dressler syndrome, which is called as, right, which is called as post myocardial infarction pericarditis. So if you take this post myocardial infarction pericarditis, like what exactly happens is, not immediately after the development of MI, after few days to weeks after the development of MI, there can be inflammation of the pericardium. That is called post myocardial infarction pericarditis, which is called the Dressler syndrome. And so basically, this is also the antibodies which are being formed against the inflamed myocardium that will be causing pericarditis. So you need to give the anti-inflammatory drug, that is high dose of aspirin should be given in these patients with post myocardial infarction pericarditis, that is Dressler syndrome. So how did we classify the etiologies now? Infectious causes, most among that will be viral etiology. Then non-infectious, idiopathic, we don't know what is the most common cause, right? And the other causes will be like renal failure, like metabolic causes and all. Then autoimmune, like we have rheumatic fever, collagen vascular disease, drug induced, and then Dressler syndrome. Okay, now let me take up the discussion of the clinical features in patients with the pericarditis. So what will be the clinical features? Definitely it is the chest pain. Okay, And where will be the location of this particular chest pain? The location of the chest pain which is there over the precordium, right? And it is very severe pain, right? And where will be the location of this particular pain? The location of this pain, it will be retrosternal in location, or it will be onto the left side of the precordium. And this particular pain, that will be referred to the neck. So where will be the radiation of the pain? Radiation of the pain is towards the neck. Radiation of the pain is to the arms. The radiation of the pain is to the left shoulder. Okay, so these are the sites where the pain will get radiated. And if you take the character of the pain, the character of the pain is, it is the pleuritic type of chest pain, right? The character of the pain is, it is the pleuritic type of chest pain, okay, where you have the inflammation of the pleura as well. I mean, in a sense, what I mean to say is, like in case of pleuritis, what will be the character of the pain? The same pain you have even in case of pericarditis also. Now, how will be that? This particular pleuritic type of chest pain, it will be a very sharp pain. And this particular pain, it is aggravated by inspiration, right? It is aggravated by inspiration because there will be the expansion of the lung parenchyma which comes in contact with the pericardium, inflamed pericardium, and the pain increases. And this particular pain also increases on coughing. So why is that on coughing? See, even when the individual is coughing, right, if you just observe carefully, the individual will take a high volume of air inside and then coughs out. Okay, so whenever the individual is taking a high volume of air inside, there will be expansion of the lung that comes in contact with the inflamed pericardium, causing pain, increase in the intensity of the pain. So pain increases on inspiration and as well as the coughing. Okay, right. And so now what are the aggravating factors for the pain? The aggravating factors for the pain is upon inspiration, right? Upon inspiration. And this particular pain is also intensified by lying supine position, right? By lying down in supine position also the pain will get intensified, and this particular pain, it is relieved. See, why upon lying down position? Multiple reasons we can just consider into. See, in the lying down position, you know, the diaphragm, the gastric contents or the abdominal contents will be pushing the diaphragm up, and this diaphragm, if it comes in contact with the inflamed pericardium in the supine position, you know, there can be aggravation of the pain. The other reason is that in the supine position, the venous return also increases, and there can be the distension of the ventricles or the distension of the chambers of the heart, which comes in contact with the inflamed pericardium, and thereby the pain will increase. Okay, and this particular pain, it is relieved, right, by sitting up, right? Because sitting up, the venous return reduces, and leaning forward, right? And leaning forward, the pain will be reduced. Okay, so this will be the character of the pericarditis pain. And one point what you have to understand is that the pain will be radiating to the neck, arms, and as well as even the left shoulder. And sometimes the pain also will radiate to the trapezius muscle. Okay, sometimes the pain will be radiating to the trapezius ridge as well. So now, because the pain is radiating to this particular structure, you know what will be the close differential diagnosis for the pain of pericarditis? That will be the myocardial infarction. So acute myocardial infarction is one of the very important close differential diagnosis for the character of this pericarditis pain. But when there are certain etiologies causing pericarditis, the pain is absent. Now, what are those etiologies? So if the pericarditis is secondary to tuberculosis, the pain is absent. Then post irradiation, right? Post irradiation, the pain is absent. And if the etiology of the pericarditis, if it is neoplasia, then also the pain is absent. And if the etiology of the pericarditis, if it is uremia, that is uremic pericarditis, then also the pain will be absent. So these are very, very important things, because if these etiologies are causing pericarditis, the pain will not be there. Okay. And what we need to know is why there is no pain if the etiology of pericarditis is like tuberculosis, post-irradiation neoplasia, and as well as uremia. The reason is that, like in case of tuberculosis or post-irradiation, in all these cases, the onset of inflammation is very slow, right? And at the same time, there can be also fibrosis of the pericardium, because the onset of the inflammation and the progression of the inflammation is a slow process. The body, it gets accustomed to that particular slow onset mild inflammation. Okay, whereas you take the viral etiology associated pericarditis, it's an acute pericarditis. The inflammation is like very severe and abrupt in onset. But whereas in case of tuberculosis or like post irradiation, the onset on inflammation and the progression of the inflammation is very mild and as well as slow. And that is the reason why you don't have the pain of the pericarditis in these conditions. But it does not mean that if pain is not there, these are not the serious conditions. Okay, if they are not being treated, they go into a state of heart failure, and there can be development of arrhythmias as well, and wherein the individual can have sudden cardiac death also. Okay, so they definitely have to be treated. It does not mean that if the pain is not there, that they are not the serious conditions. Okay, now if you take the differential diagnosis of the pain of the acute pericarditis, the differential diagnosis of the pain of acute pericarditis is the acute myocardial infarction. Okay, so even in case of the acute myocardial infarction, the pain will be retrosternal, right? The pain will be retrosternal, and that will be radiating to the left arm and as well as the shoulder and as well as the left jaw. Okay, and the cardiac biomarkers, they are elevated. They are also elevated in even in case of pericarditis, and even in case of acute myocardial infarction also the cardiac biomarkers are elevated. And we have a terminology called epimyocarditis. Epimyocarditis is what, when the inflammation from the epicardium, if it is being transmitted to the myocardium, that we call it as the epimyocarditis. And because of this epimyocarditis, your cardiac biomarkers, that is troponin and as well as the CKMB, both of them are elevated. Now, the point of the differentiation is on the ECG. So, if you take the ECG manifestation in case of the acute pericarditis, in acute pericarditis, you have ST segment elevation in all the leads. So, it will be global ST segment elevation, and that too, it will be a concave ST segment elevation in all the leads, except there will be ST segment depression in AVR, right? In AVR, there is ST segment depression. And not only that, even the other important ECG changes will be the PR segment depression will be there in all the leads, except in AVR, you have the PR segment elevation. So the development of PR segment depression, that tells you it is an atrial involvement. Okay, it tells you the atrial involvement. Now, what will be the auscultatory finding in patients with acute pericarditis is, you will listen the pericardial rub. Okay, and this pericardial rub in case of acute pericarditis, it is seen in almost 85% of patients with the acute pericarditis. Now, let me discuss few important points about this, the pericardial rub. So, this rub of acute pericarditis, it has three components. Okay, it has three components per cardiac cycle. And what is it described as? It is described as rasping, scratching type of pain, right? Scratching type of pain, or it is of grating in character, right? Or it is of grating in character. And this rub of pericarditis, it is most frequently heard at end expiration. Right? It is most frequently heard at end expiration. And what should be the position of the patient when you are auscultating for the pericardial rub is, the patient should be made to sit upright. Right? The patient is made to sit upright and leaning forward. Right? And leaning forward. So this is the position in which you can characterize the pericardial rub thoroughly. Okay, so this is about the pericard, but this pericardial rub, you don't have this in case of the acute myocardial infarction. You have that only in patients with the acute pericarditis, and that is another important differentiating point from the acute myocardial infarction. Okay, next. Then the next important is the ECG changes in acute pericarditis. Just now we were discussing, but if you take the ECG changes in case of acute pericarditis, they typically evolve through 4 stages, right? They typically evolve through 4 stages. So now what will be the stage 1 changes? The stage 1 changes is that there will be concave ST segment elevation in all the leads, right? Concave ST segment elevation in all the leads except AVR, where you have, right, where you have ST segment depression. Okay, and what about the PR segment? You have global PR segment depression except PR segment in AVR, there will be PR segment elevation. That is what you will observe in stage 1. Okay, right. And what about the QRS complexes in case of your acute pericarditis? Remember, there will be no abnormality within the QRS complexes. The QRS complexes in case of pericarditis, they remain absolutely normal. Then what is stage 2 of your acute pericarditis? The ST segment elevation, whichever has developed in stage 1, that will return back to normal. Okay, the ST segment elevation, that will return back to normal. That is what you will observe in stage 2. Whereas you take in case of stage 3, right? In stage 3, the T wave, it becomes inverted, right? And in stage 4, what is that you will notice is that all the changes, whatever have appeared, that is after weeks or months after acute pericarditis, the ECG changes will return back to normal. Okay, so that will be the stage 4 of the acute pericarditis. Now let me show you that ECG changes, whatever we have discussed. So if you observe here very carefully, you have the concave ST segment elevation, right? You have the concave ST segment elevation in all the leads except your AVR. You have ST segment depression. The other thing is the PR segment. So if you carefully observe the PR segment, it is depressed in all the leads. And always you have to compare the PR segment with the TP segment. So the TP segment, see, this is your TP segment. Okay, so this particular TP segment is considered as the isoelectric baseline. So with the TP segment, you need to compare the PR segment. So you will find that the PR segment is depressed, except in AVR, the PR segment is elevated. Okay, PR segment will be elevated in case of your AVR. So this is about the ECG changes that you come across in patients with the pericarditis, and in 4 stages. In stage 1, you get all these characteristic changes, whereas in stage 2, what happens is these particular ST segment elevation, whatever has occurred, that will return back to normal. And in stage 3, T waves, they become inverted. And in case of stage 4, all the changes will return back to normal. Okay. Now, these are the ECG changes in case of the acute pericarditis. Then, how is this different from the acute myocardial infarction? In case of acute myocardial infarction also, you have ST segment elevation. But in case of the acute myocardial infarction, what will be the earliest change? The earliest change in case of the acute myocardial infarction is the presence of tall T wave. Right? The presence of tall T wave. And this particular tall T wave, please remember, it is broad tall T wave. And you have a differential diagnosis for this tall T wave. The differential diagnosis for this particular tall T wave is nothing but hyperkalemia. But in case of hyperkalemia, it is tall tented T wave. Okay, right? And whereas here it is broad tall T wave, right? Next, then coming to after your tall T wave, then you get this ST segment elevation, but this will not be global ST segment elevation. The ST segment elevation in case of myocardial infarction corresponds to only to that particular wall. If it is like anteroseptal wall MI, you have ST segment elevation from V1 to V4. And if it is inferior wall MI, you have ST segment elevation in 2-3 AVF. right? And if it is lateral wall MI, then the ST segment elevation will be there only in one AVL, V5 and as well as V6, okay? But in case of pericarditis, what did we discuss? We have the ST segment elevation will be there in all the leads except for your AVL. And one point what you have to understand in case of acute pericarditis is that what will be the earliest ECG change in case of the acute pericarditis? Remember, it is not your concave ST segment elevation. Okay, the early change will be the PR segment depression. Okay, so the PR segment depression, that may occur prior to the ST segment elevation. Okay, this will be the early change in case of the acute pericarditis, and after that you get ST segment elevation, which is of concave morphology. Now, what are the other ECG changes? So you have the development of deep and pathological Q wave, right? Deep and pathological Q wave. So if you take this particular Q wave, the depth of the Q wave will be more than or equal to 1 mm and width will be more than or equal to or more than 40 milliseconds. That will be the pathological Q wave. And at one point of time, the R wave will disappear. At one point of time, the R wave will disappear. And in the leads where you have MI, like for example, if it is anteroseptal MI, in V1 to V4 you have ST segment elevation. But in reciprocal leads are the inferior leads. In reciprocal leads, you will notice that there is ST segment depression. But in acute pericarditis, you will not have these reciprocal changes. So in that way, you can differentiate the ECG of acute pericarditis from the ST elevation MI. Okay, right. So right, after having discussed about the ECG changes in case of the acute MI, you need to know that in patients with pericarditis, one of the complications that can develop is the pericardial effusion. Now, how can you identify that the individual has developed pericardial effusion? So there are various methods. One is by your ECG. So ECG, it will show you that there is low voltage complexes. Right, ECG will show you that there is low voltage complexes. What is the criteria for the low voltage complexes? The criteria for low voltage complexes is that the amplitude of the QRS complex, right, the amplitude of the QRS complex, it will be less than 10 mm in the chest leads, right, and it will be less than 5 mm in the limb leads. Okay, so this will be the ECG changes in case ECG of the low voltage complexes. Where will you have this? Whenever there is pericardial effusion. If there is like large pericardial effusion or if there is like massive pericardial effusion, then the ECG what you get is the electrical alternance. Now, what do you understand by this word electrical alternance? Electrical alternance mean that you will have one complex being large, so you can see that here very clearly. So one complex will be large and the another complex will be small. You have large and small complexes, large and small complexes. This electrical alternance, you will have this whenever there is massive pericardial or large pericardial effusion. Okay, and you can also have this if the individual has developed cardiac tamponade. So even in cardiac tamponade also you have this electrical alternance. Okay, right. So that is about your methodology by which you can diagnose the pericardial effusion. And how will you make out or what exactly is your cardiac tamponade? If the pericardial effusion, whichever is developing, right, if it is very abrupt in onset, right, if the pericardial effusion, whatever is developing, if it is abrupt in onset, then we call it as the cardiac tamponade. Then in case of pericarditis, like we have discussed that there will be pericardial rub, right? But what will be the auscultatory finding in case of pericardial effusion? In pericardial effusion, the heart sounds, they become muffled because of the presence of the fluid, right? Because of the presence of the fluid, the transmission of the heart sounds to the surface of the chest will not occur appropriately. So thereby the heart sounds, they become muffled. And the another important point is the pericardial rub or the friction rub. So if there is pericardial effusion, the friction rub, it disappears. The friction rub, it disappears. And even the apical impulse also disappears on auscultation. Then you need to know about what is called as Ewart sign in patients with the pericardial effusion. See, what is this Ewart sign is? Whenever there is large pericardial effusion, this large pericardial effusion, it can cause the compression of the lung parenchyma, right? It can cause the compression of the lung parenchyma. So over the compressed lung parenchyma, what you do is, right, you try to auscultate and you also try to do the palpation as well. So you will notice that there is increased vocal fremitus, where because of large pericardial effusion, the large pericardial effusion will be compressing the surrounding lung parenchyma, basically the base of the lung. So base of the lung, it will get compressed. So in that area, you try to elicit this vocal resonance. The vocal resonance or the vocal fremitus will be increased. So vocal fremitus is basically a palpatory finding. Vocal resonance is nothing but the auscultatory finding. And because the lung parenchyma is being compressed or consolidated, on percussion, you will find the dullness. And very important sign of consolidation is the egophony. So you will also listen the egophony. Okay, so egophony is actually the sign of consolidation, right? Because here lung parenchyma is getting compressed and consolidated. So that is the reason why you will have the egophony. And that too, which particular lung? That is mainly the left lung. And next important thing is the chest x-ray. So what is that you will find in the chest x-ray of patient with pericardial effusion is that you will see a water bottle appearance. Okay, so you will have this characteristic water bottle configuration. These patients, the pedicle, they'll have a narrow pedicle, but if you take the entire cardiac shadow, that will be of the water bottle configuration. Okay, right. But if this water bottle configuration is seen mainly whenever there is large pericardial effusion. If it is like small pericardial effusion, the chest x-rays may be normal. Okay, so this is about the findings in case of the pericardial effusion. But what is the most widely used investigation for diagnosing pericardial effusion? That will be your 2D echo. So 2D echo, it is the most widely used investigation or imaging technique for picking the pericardial effusion. So if you take the sensitivity and as well as specificity for diagnosing pericardial effusion by your 2D echo, the sensitivity and specificity, both of them, they are very good. And this particular 2D echo, it is a simple and non-invasive investigation. Right, it is a simple and non-invasive investigation, and this may be performed bedside. And the importance of this 2D echo is that this will help in localizing the area of, right, this will help in the localization of where exactly the fluid, and this will also help in estimating the quantity of the fluid. Right, this will also help in estimating the quantity of the pericardial fluid. So that is about your 2D echo. Then in the 2D echo, you will also be able to make out the echo free space, right? So basically what you will be doing is a transthoracic echocardiography, and this is what is your echo free space. Okay, this is your echo free space, right? So this is your parasternal long axis view. So you have the presence of the echo-free space. So where exactly you find this particular echo-free space? This particular echo-free space, it is present between the posterior pericardium, right? The word PP stands for posterior pericardium, and as well as left ventricular epicardium. Okay, so this is one place where you can find the echo-free space, right? The other place where you can find the echo-free space is between the anterior right ventricle, right, between the anterior right ventricle and parietal pericardium. So there also you can find the echo-free space. So this is about your 2D echo for diagnosing the pericardial effusion. But for diagnosing the pericardial effusion, the other investigations are the CT and as well as MRI. So CT and as well as MRI for the diagnosis of the pericardial effusion, they will confirm the diagnosis of the pericardial effusion, both CT and as well as MRI. So what is that you will observe? You will observe that there is presence of the pericardial fluid, and you will also notice that there is thickening of the pericardium, right? Thickening of the pericardium. And your CT and as well as MRI, they are much superior compared to that of the 2D echo, right? And this particular MRI will also be very much useful in detecting the pericardial inflammation, right? In detecting the pericardial inflammation. Now, in what way your CT and MRI, they are superior to 2D echo, right? So this CT and MRI, they detect the loculated pericardial effusion. So if there is any loculations that can be made out by your CT or MRI, right, you will be also able to make out the presence of the pericardial thickening by your CT or MRI, and you will be also able to identify if there is any presence of the pericardial masses. Okay, so in this way your CT and MRI, they are superior to 2D echo. Now let me show you the imaging, right? So this is the short axis view, right? So this is the short axis view of the MRI, where you are able to make out, right, where you are able to make out that there is thickening of the pericardium. Okay, so this is a T2 weighted images, and this is a long axis view, right? So this is the long axis view, so you can make out the thickening of the pericardium carefully here, right? So, and here what we use is a contrast, and that particular contrast is the gadolinium. So there will be late gadolinium enhancement of thickened inflamed pericardium, right? Late gadolinium enhancement of thickened inflamed pericardium. So that is what you will observe in the long axis view. So after having discussed about the differential diagnosis and diagnosis of pericarditis, now you need to know how do you treat these patients with the acute pericarditis. You need to give an anti-inflammatory drugs, and that particular anti-inflammatory drugs are non-steroidal anti-inflammatory drugs. So because they will suppress the inflammation of the pericarditis. So the main drug is your aspirin, right? That will be the first line drug, and the dosage will be around 2 to 4 grams per day. So you need to give high dose of aspirin. And if you are giving ibuprofen because aspirin is contraindicated, then the ibuprofen that you need to give is 600 to 800 grams per day. That will be the dosage of the ibuprofen. And indomethacin, if you are giving, then the dosage will be 25 to 50 milligrams, and this has to be given thrice daily. These are the drugs which can cause severe gastritis. Okay, so in order to prevent the gastritis, you need to give proton pump inhibitor, that is the omeprazole, and this particular omeprazole, right, you should give 20 milligrams per day. So this will be the treatment for the acute pericarditis, right? And those patients who are responsive to your NSAIDs, okay, these, for how long you need to continue these drugs? These drugs, either of any drug, right? Not all these drugs should be given in one patient. So either of these drugs should be given, right? And in responsive individual, these drugs have to be continued for nearly around 1 to 2 weeks. Then they have to be tapered over several weeks. Right? They have to be tapered over several weeks. So this is about the treatment of the acute pericarditis with non-steroidal anti-inflammatory drugs. Now, what is the indication of the colchicine and what is the dosage of it? So, if you take the dosage of the colchicine, the dosage is just 0.5 milligrams per day, right? 0.5 milligrams per day. That is in case of an individual who is less than 70 kg. But in individual who is like more than 70 kg, in them, you need to give more than 0.5 milligram of the colchicine per day should be given. Okay. And for how long you will give this? You have to give this colchicine for nearly around 3 months. Okay. But whereas the non-steroidal anti-inflammatory drugs, we were giving only for 1 to 2 weeks. But colchicine, if you are giving, you need to give for nearly around 3 months. And what is the advantage of the colchicine? See, this particular colchicine will enhance, right, will increase the response of the NSAIDs, right, will enhance the response of the NSAIDs. The advantage of this colchicine is that it will reduce the risk of recurrent pericarditis, right? It will reduce the risk of the recurrent pericarditis. So that is the advantage of giving the colchicine, right? And what are the adverse effects of this colchicine? The adverse effects include the diarrhea. So diarrhea, it is a very, very important adverse effects, right? And in which conditions this colchicine is contraindicated? So if there is the renal failure, okay, or the hepatic failure, then the colchicine, it should be avoided or contraindicated. So that is about the story of colchicine. Importance is that it will reduce the recurrence of pericarditis. And the other group of drugs are the glucocorticoids. And among the glucocorticoid, what we give is prednisolone, and the dosage of the prednisolone is around 1 milligram per kg per day. So because even your glucocorticoid, that is prednisolone, also has the anti-inflammatory activity, and that is the reason why you need to give glucocorticoids. But what are the indications for giving glucocorticoids? Indication is that who have failed response with NSAIDs, right? Who have failed response with NSAIDs, or who cannot tolerate the NSAIDs, right? Who cannot tolerate the NSAIDs. In them, you need to give this particular glucocorticoids. Okay, so either, I mean, there is no response with NSAIDs, or even there is no response with colchicine. That is the point when you need to give glucocorticoids. But occasionally, you need to give full dose of nearly total 1 milligram per kg per day. Okay, so when should you give, right? So whenever you feel that there is increased risk of subsequent recurrences, full dose steroid should be given for nearly around 2 to 4 days. So those individuals who have the high incidence of recurrence, in them you need to give full dose of the glucocorticoids, and then gradually you need to taper. But very important point is, whenever you are giving this anticoagulants, they should be avoided in patients with the acute pericarditis. Why? Because the supplementation of the anticoagulants could cause bleeding into the pericardial cavity, right? They can cause bleeding into the pericardial cavity. So by causing bleeding into the pericardial cavity, this makes the individual to develop cardiac tamponade. So that is the reason why your anticoagulants are contraindicated, or they should be avoided in case of the pericarditis. So you need to be very careful in your diagnosis. If it is an MI, definitely you need to give your anticoagulants. But if it is pericarditis pain, you should not give the anticoagulants. Okay. Now, in refractory cases, you have given NSAIDs, no response, colchicine, no response, glucocorticoids, no response. So in those individuals where there is no response to either of these drugs, then you need to treat the patient with interleukin 1 beta receptor antagonist. So interleukin 1 beta receptor antagonist. Right? And what is the example of this? The example is the azathioprine or the anakinra. So these are the interleukin 1 beta receptor antagonists, right? And they have been reported to be of beneficial use in refractory cases. The other modality of the treatment for refractory cases is the pericardial stripping. But doing of this pericardial stripping, it is rarely being done, right? And however, this procedure may not always terminate the recurrences. In spite of doing the pericardial stripping, there is chance of recurrence over the leftover pericardium. Okay, then what are the indications for hospitalization in patients with the pericarditis? Okay, so like you have when specific causes, like for example, tuberculosis is causing pericarditis, or some neoplasia is causing pericarditis, right? Or some bacterial infection, right? Or bacterial infection has caused pericarditis, then they require the admission. Okay, so because these etiologies causing pericarditis, they have like poor prognosis. And what will be the poor prognostic factors where they require the hospital admission? If the individual has developed fever and the temperature should be more than 38 degrees centigrade, right? And it should be subacute in onset. Okay, within the duration of the pericarditis should be around 6 weeks to 6 months. And if there is presence of the large pericardial effusion on the 2D echo, so that tells these patients require hospital admission and the prognosis is not that good. All right. Then coming to the discussion of the individual etiologies causing the pericarditis. So what did we discuss? The most common cause will be definitely infectious cause. Among the infectious cause, like even though we use the word idiopathic, but the presumed etiology is of the viral origin, right? The presumed etiology is of viral origin. So what these patients will have the past history. So they have antecedent history of the respiratory infection, a past history of the respiratory tract infection. Okay, and this respiratory tract infection, they are mainly caused by the viruses. They are mainly caused by the viruses, and these viruses, they cannot be isolated. Okay, isolation of these viral organisms is difficult. So that is the reason why the serology usually comes as negative. Right, the serology usually comes as negative. Now, what are those viruses? Just now we have discussed. Let me repeat once again. That includes Coxsackie A and as well as B virus, then ecovirus, herpes virus, the influenza virus, varicella zoster virus, adenovirus, cytomegalovirus. Okay, so these viruses, they have been isolated from the fluid of the acute pericarditis patient. Okay, then now when do we use the word idiopathic? For example, viral etiology has come negative and we don't know what is the underlying cause, then we use the word idiopathic acute pericarditis, right? If viruses cannot be established, right? If the viruses, if they are not being established, then we call it as idiopathic pericarditis, right? Then if you take the ages, right, this viral or idiopathic acute pericarditis, this occurs in all ages, right? This occurs in all ages, but is most common in young adults, adult males, then compared to that of the females. Okay, it is more common in males than compared to that of the females. And if you take the clinical features of the viral origin pericarditis, the clinical features is that similar to that of your acute pericarditis, but only thing is that these patients, they also develop the presence of fever and as well as the pain of the acute pericarditis. Okay, so simultaneous development of fever and as well as the precordial pain, right? So this particular clinical feature, they develop usually after 10 to 12 days of, right, 10 to 12 days after viral illnesses, right? There is development of fever and as well as the pain. Okay, and now serology, what did I discuss? Most of the times they may get picked up and sometimes they may not be picked up. In such case, we need to call it as the idiopathic pericarditis. Okay, and what are the viruses? Just now we have discussed, that is the Coxsackie virus, then adenovirus, then influenza, herpes simplex virus, cytomegalovirus. So these are all the varicella zoster virus. So these are all the viruses that are responsible for the development of your viral pericarditis, right? Then if you take the clinical features, yeah, so the clinical features is what just now we were discussing actually, that is your fever and as well as the pain. And an auscultation in case of acute pericarditis also, you have the pericardial rub and what is its character and how do we need to examine, all that we have discussed. And what will be the duration of the chest pain. Okay, so like if you see fever and as well as the precordial pain, what is that I have discussed? They should be there 10 to 12 days after the presumed viral illness, right? And if you take the pain of the pericarditis, the pain of the pericarditis or the disease of viral pericarditis, it has a course. Okay, so it will be there for few days to weeks, right? It will be there for few days to weeks. And how do you work up? Because it's an inflammatory pathology, so your CRP and as well as the ESR, they are being elevated. And what will happen to your WBC count? Because it's an infectious pathology, the WBC count is being elevated. And if you do an ECG will show you that there is global ST segment elevation, except for your AVR where there is ST segment depression. And what will happen to your PR segment? PR segment will be depressed except for your AVR where the PR segment is elevated. And the other important ECG abnormality is the T wave is being inverted, and that will be there for several years. Okay. Now, what are the complications that can be anticipated in case of any forms of pericarditis? Not only viral, you take any form of pericarditis, the complication that is being anticipated is the development of the pericardial effusion or the development of the cardiac tamponade. Okay, so these are the complications that can be anticipated with the viral pericarditis, right? Then followed by that, see what will be the treatment? Same, that is anti-inflammatory drugs, whatever just now we have discussed, that is your NSAIDs, colchicine and as well as corticosteroids. So the next important point of discussion is about the post-cardiac injury syndrome. So this is also, one of the etiology that can cause the pericarditis. Now what exactly is that? It is post-cardiac injury syndrome. So this is actually a result of the hypersensitivity reaction. And this particular hypersensitivity, okay, so this particular hypersensitivity, it originates, right, it originates from injured myocardium, right? It originates from the injured myocardial tissue or from injured pericardium, right? And this particular hypersensitivity, we call it as an autoimmune in nature, right? So it originates from the injured myocardium or the pericardium. So basically what happens here is the individual either might have an injury to the myocardium, right? Like let us just say the patient has developed pericardial effusion, and the type of pericardial effusion, it is hematogenous pericardial effusion, right? And the blood which is there within the pericardial space, that can induce the hypersensitivity reaction against the pericardium, causing pericarditis. Okay, so in that way, like you take the another example. If suppose a catheter is placed within the pericardial space, like you have done a pericardiocentesis and you have placed the catheter within the pericardial space, so there can be hypersensitivity reaction against the catheter, and the antibodies which are formed against the catheter can be inducing the inflammation within the pericardium, causing pericarditis. Okay, so that is what is called as post cardiac injury syndrome, right? Now these patients, they, what will be the clinical manifestations? So they definitely have the pleuritic type of chest pain similar to that of the pericarditis, but along with that, these patients will also have the presence of the pericardial effusion, right? So if it is like blood may be there. If it is hematogenous cause for your post cardiac injury syndrome, like if it is like catheter induced post cardiac injury syndrome, or if it is like trauma induced post cardiac injury syndrome, then in such case what you will have is you have the presence of the fluid in the pericardial space, and the pericardial effusion will be there. That will be serosanguinous in nature, right? This will be serosanguinous in nature, and rarely this pericardial effusion, it can progress to the development of the cardiac tamponade as well, right? Rarely this can progress to the development of the cardiac tamponade as well. And the pericarditis, what these individuals develop, this particular pericarditis, this will be fibrinous variety or fibrinous pericarditis, right? So that is what is the type of pericarditis that you will have in case of the post cardiac injury syndrome, right? And the clinical picture, as already I have discussed, it is similar to that of the viral or the idiopathic pericarditis, right? It is similar to that of viral or idiopathic pericarditis. So in the sense, these patients, right, these patients, they develop the chest pain. Okay, that will be the principal symptom of the post cardiac injury syndrome. And this post cardiac injury syndrome, you know, this develops 1 to 4 weeks after the cardiac injury, right? 1 to 4 weeks after the cardiac injury, you have the development of post cardiac injury syndrome, right? And these recurrences are very common with post cardiac injury or post cardiac injury syndrome. And these recurrences, they may occur up to 2 years or more even after the injury. So because it's an inflammation along with the chest pain, these patients can also develop fever, right? These patients can also develop fever, and the ECG changes will be similar to that of your acute pericarditis. Okay, and as such, no specific treatment is necessary again. The previously whatever you were giving for pericarditis, like we were giving aspirin, right? Or we were giving the colchicine, okay, that is analgesics. These drugs will suffice. There is no specific drug again to be added apart from these drugs. And with that is about your post cardiac injury syndrome. So basically what you need to remember is it is a hypersensitivity reaction secondary to the blunt injury to the chest, secondary to the trauma to the heart or myocardium, secondary to the catheter which is inserted into the pericardium, secondary to the presence of the hematogenous type of the pericardial effusion. Okay, right. Now if you take the differential diagnosis, because there is no specific test for acute idiopathic pericarditis, the diagnosis is one of the exclusion. That means you need to rule out all other causes which are causing chest pain. After ruling out other causes, then if no other cause has been made out, like acute MI, not there, heart failure, not there. Okay, because even though in heart failure you don't have the chest pain, but usually it is of the myocardial infarction, or the other features like pleuritis, not there. Okay, so if all other etiologies causing chest pain is ruled out, then the exclusion that you need to keep it is the pericarditis. Okay, right. Now we have discussed that the pericarditis can occur secondary to collagen vascular diseases like your systemic lupus erythematosus, or even drug-induced lupus can be there. So systemic lupus erythematosus, already we have discussed that the anti-nuclear antibody levels are elevated. And not only that, in patients with SLE, the anti-ds-DNA, that is double-stranded DNA, and as well as the anti-Smith antibodies, right? So these will be elevated. Then how do you treat? If it is like SLE induced pericarditis, you need to give corticosteroids, and that particular corticosteroids that you will be giving is prednisolone. And you have to understand that in SLE, like it is pancarditis, pericarditis will be there, myocarditis will be there, endocarditis also will be there. And that endocarditis, what we call this as Liebman-Sachs endocarditis. But among this peri, myo and as well as endo, pericarditis is the most common cardiac manifestation in patients with the SLE. Okay, and drug induced, just now we were discussing the drugs like hydralazine, then procainamide, then the isoniazid. See, these are the drug induced pericarditis. And not only that, even these particular drugs will also cause drug-induced lupus as well. Now, in case of drug-induced lupus, the antibodies are not the same. Like your anti-dsDNA, anti-Smith, they are not the same. The antibodies in case of drug-induced lupus will be the anti-histone antibodies. Right, so that will be the anti-histone antibodies. Okay, then you take another form of pericarditis that is called pyogenic or the purulent pericarditis. So pyogenic or purulent pericarditis, what did we discuss? The organisms are pneumococcus, staph, then Neisseria. These are the bacterial infections that can cause the pericarditis. Okay, now what will be the etiology for the development of pyogenic pericarditis is it is usually secondary to cardiothoracic operations. Right, it is secondary to cardiothoracic surgeries, or this pyogenic pericarditis can develop as an extension of infection from the lung, right, as the extension of infection from the lung or the pleural cavity, right, lung or the pleural cavity, and even the rupture of the esophagus into the pericardial sac. Okay, rupture of the esophagus into the pericardial sac, even that can also induce the development of the pyogenic pericarditis. Not only that, even you take the if you take the entire heart, you have endo, myo and pericardium. If there is infective endocarditis which has developed, causing the development of the ring abscess across the valve, right, ring abscess across the valve, and if this particular ring abscess across the valve, if it is being ruptured, even that can also spread to the pericardium, causing pericarditis. So these are all the sources of the pyogenic pericarditis. Okay, and this pyogenic pericarditis, right, these patients, they have a very high grade fever, right, they have a very high grade fever, and the pain also will be a very severe pain. right? And this particular high grade fever, it is associated with chills and rigors. And these patients, occasionally, they go into a stage of sepsis and as well as the septic shock. And these patients with pyogenic pericarditis, they have poor prognosis. The prognosis is not good, right? And how is this diagnosis made now? In case of pyogenic pericarditis, the investigation of choice is that you need to examine the pericardial fluid, right? So you need to do a pericardiocentesis, take out the pericardial fluid, and you need to examine that pericardial fluid, right? Wherein you need to make out the culture and sensitivity, and you need to pick up the organism growing in the pericardial fluid, okay? And these patients, how do you treat? These patients, they require immediate drainage, right? They require immediate drainage, and along with that, vigorous antibiotics should be given. Right, along with that, vigorous antibiotic treatment should be given. So this is for your pyogenic or the purulent pericarditis. Then next to this, you have the pericarditis of the renal failure. So if you see the pericarditis of renal failure, which is also called uremic pericarditis. So in renal failure, what exactly happens is there will be increase in the urea and as well as the creatinine. And that urea which is being elevated, that will get accumulated within the pericardium, causing uremic pericarditis. So if you take the pericarditis in renal failure, we have two forms. One is uremic pericarditis, right? And the other one is the dialysis associated pericarditis. Right, dialysis associated pericarditis. Okay, so this uremic pericarditis, it is seen in almost 1/3 of patients with severe renal dysfunction. Right, in 1/3 of patients with severe renal dysfunction, there is excessive increase in your urea, and that excessive increase in urea can get accumulated within the pericardium, causing uremic pericarditis. And that excess urea can also cross the blood-brain barrier, can also make the individual to develop uremic encephalopathy, and the excess urea can also accumulate within the stomach, resulting in uremic gastroparesis. Okay, and because of the uremic gastroparesis, the individual will have the hiccups, vomiting. So all these will be there. And now you take this dialysis associated pericarditis. Dialysis associated pericarditis is that it is seen in patients who are undergoing chronic dialysis, right? Who are undergoing chronic dialysis. In them, you come across this dialysis associated pericarditis. Okay, right. Now, these patients with dialysis associated pericarditis, the blood urea nitrogen levels may remain normal, right? May remain normal. So these are the two forms of pericarditis which you come across in patients with the renal failure. And the type of pericarditis that you come across in both of them, it is the fibrinous pericarditis. Okay, it is a fibrinous pericarditis. Okay, and if you take the fluid, what will be the consistency of the fluid? It is serosanguinous effusion, right? Serosanguinous effusion. But occasionally, in case of the uremic pericarditis, there can be presence of blood, and that we call it as the hemorrhagic pericarditis. Okay, occasionally in uremic pericarditis, there can be presence of frank blood, that we call it as the frank hemorrhagic effusion. Okay, right. Then next to this, the few more points about the uremic pericarditis is that these patients, they don't have the chest pain. Already we have discussed. Why? Because the onset of inflammation and the severity of the inflammation is mild. So it's a very slow onset of the inflammation. So the body gets accommodated to that mild and slow onset inflammation, wherein the pain will not be there. But is it not serious? It is very serious. The individual may land up into the heart failure. Okay. But when you auscultate, you will be able to listen the pericardial rub. But only thing, the chest pain is not there. So how do you treat these patients is the same thing. Like you need to give non-steroidal anti-inflammatory drugs, that is you need to give aspirin, and you need to intensify the dialysis. Like if it is like uremic pericarditis, then you need to intensify the dialysis. Okay, so that will be more than adequate. And these patients with uremic pericarditis, the very important complication they can develop is they can develop the cardiac tamponade, where there will be abrupt accumulation of the fluid in the pericardial space. And once there is development of a cardiac tamponade, then you need to do pericardiocentesis. right? And this particular pericardiocentesis, what should be the approach of the pericardiocentesis? It should be subxiphoid approach, right? Through subxiphoid approach, you need to enter into the pericardial space and take out the fluid from the pericardial space. Okay. Now, when the pericarditis of renal failure is recurrent or persistent, then, okay, the pericarditis of renal failure, if it is recurrent or persistent, then what is that you need to do? You need to create a pericardial window, right? And through this pericardial window, you need to send a catheter, right? A pericardial window should be created, or you have to do pericardiectomy, right? You have to do pericardiectomy. So when will you do that? When the pericarditis of renal failure, if it is recurrent or persistent, then you need to create the pericardial window, or pericardiectomy should be done. So this is about your uremic pericarditis. Okay. Then you need to know the pericarditis due to the neoplastic diseases. So you take the malignancies, right? So you have the benign and as well as the malignant conditions of the lung which can cause the pericarditis, and apart from that, metastasis to the lung, or sorry, metastasis to the pericardium, that can also cause the pericarditis. Okay, so pericarditis due to neoplastic diseases are mainly due to extension or invasion, right? Extension or invasion of metastatic tumors. Right? And what will be these metastatic tumors? Where are they coming from? They are most commonly coming from carcinoma of the lung. Right? They are coming from the carcinoma of the breast and extending into the pericardium. Next, malignant melanoma. Right? And the other primary will be lymphoma or leukemia. Okay, so these will be the primaries. So from these areas, the tumor can spread into the pericardium, causing the pericarditis, right? And if you take the clinical features here, definitely you will have the pain of the pericarditis, and the complications are there can be development of cardiac tamponade. And once there is development of cardiac tamponade, what will be the clinical manifestation is sudden onset dyspnea. Basically in cardiac tamponade, you know, there is abrupt increase in the pressure in the pericardial space, right? Pericardial pressure, PP, pericardial pressure is abruptly increased, and that will cause diastolic collapse of the ventricle. Ventricles, they cannot relax at all because of increase in your pericardial pressure. So once there is diastolic collapse of the ventricle, the atrial pressures are elevated, and there will be backflow of the blood from left atrium to the pulmonary veins, pulmonary capillaries, causing pulmonary edema. That is the reason why there will be sudden onset dyspnea. And the other complications of the neoplastic diseases causing pericarditis is that the other complications are the development of the atrial arrhythmias, right? These are the common complications that can be associated with pericarditis due to neoplastic diseases. And how will you diagnose? See, the diagnosis of, so the diagnosis of pericarditis due to neoplastic diseases is that you need to do the pericardial fluid analysis. And in the pericardial fluid analysis, you need to do cytology. Okay, you need to examine the cells, or you need to do pericardial biopsy. Right, you need to do pericardial biopsy. So this is about pericarditis due to neoplastic diseases. And the next important thing is irradiation. So even irradiation for neoplasm, and that too mediastinal irradiation for neoplasm, even that can also cause the acute pericarditis. But one of the very important feature that we have discussed is the irradiation causing pericarditis, there will be no chest pain. Right? Why? The same reason what we have discussed there also, that the onset and as well as the inflammation progression will be very mild. So that is the reason why the body gets accustomed to that particular inflammation which is going on minimally. So thereby the pain will not be there in these individuals. So that is about the mediastinal irradiation for neoplasm. So this completes the discussion of this very important topic, that is pericarditis. So if you take this pericarditis, right? So it is the acute pericarditis where the onset of the development of pericarditis and duration will be less than 6 weeks, subacute around 6 weeks to 6 months, and chronic beyond 6 months. And how do you classify the etiology? Infectious, non-infectious, autoimmune. Among the infectious, most common will be viral infection. And among the non-infectious, like we have like collagen vascular disorders, right? And among the collagen vascular disorders, like what do you have? SLE, right? Then systemic lupus, that is what is your systemic lupus erythematosus, rheumatoid arthritis, then scleroderma. Then apart from that, you have the rheumatic fever as well. Okay, so that can also induce the development of your pericarditis. So that will be the non-infectious, right? Remember, your rheumatic fever, it is non-infectious. It's an inflammatory origin pericarditis. And in the autoimmune, like we have like rheumatoid arthritis where you have the anti-CCP and all. Okay, so these are the etiologies causing the pericarditis. But remember, for some of the etiologies causing pericarditis, you don't have the chest pain. So what are those etiologies where you will not have chest pain? Number one, tuberculosis, post-irradiation, neoplasia, uremia causing pericarditis. In these cases, you don't have the chest pain at all. And how will you diagnose this? Apart from the characteristic features, see, what will be the close differential diagnosis? That is your MI. So how will you differentiate that pericarditis from MI? Based on your ECG finding. But remember, in both of them, the cardiac biomarkers may be elevated. Based on ECG changes, your pericarditis can be differentiated from the myocardial infarction. And in ECG changes, in case of pericarditis, you will have global ST segment elevation, and that too concave ST segment elevation in all the leads except in your V1. In AVR, you have ST segment depression. And the other important ECG finding is the PR segment depression except in AVR where you have the PR segment elevation. And what are the complications that can be seen in case of pericarditis? The complication is development of pericardial effusion and then cardiac tamponade. Okay, so how will you diagnose that there is like pericardial effusion? Either by ECG or the specific will be your 2D echo. And the other investigations are CT and as well as MRI to diagnose this particular complications. And how do you treat? Like we give aspirin, that will be the first line. Then the other drugs will be colchicine. Then the other drugs will be your corticosteroids. Then the other immunosuppressive agents that you have anakinra and all. So when the individual is refractory to NSAIDs, colchicine and the corticosteroids, then we need to give further other immunosuppressants like your anakinra and all. Okay. And in refractory cases, you need to do pericardial stripping as well. Right. So this completes the discussion of this very, very important topic, that is acute pericarditis. Thank you very much.